Hello, and welcome to the Mind series. I'm Dr. Ryan Thompson. I'm the Executive Director of Mind Matters, and I'm here today with Carina Lindblom, who's a licensed educational psychologist, and we work together at Mind Matters Clinic in Murphy's. We are a nonprofit organization, and we've been in operation for a couple of years now, and we focus on the childhood disorders and adult disorders of ADHD, autism spectrum, and learning disabilities. And the Mind series will be a series of presentations which will be focusing on those three areas. Tonight's presentation will be focusing on ADHD and its identification and how to recognize that in individuals. And a little bit of background first. I am Dr. Ryan Thompson. I've been based in Murphy's for 20 years. And I've had an interest in children with ADHD and autism for many years. And through personal experience with a son who has ADHD and autism, I learned that there really are very few resources in the region, essentially, and certainly none locally, that really address specifically the needs of these individuals, either children or adults. And so I set out many years ago to try to garner resources for our own son and also for many individuals who I saw in my practice. The more I developed an interest in a specialty in treating children and adults with ADHD and autism, the more people came to see me from not just our county, from the vicinity, from local other counties around. And so I tried with just some fits and starts and ways of trying to get these resources and really could never garner them together in one place. And so a couple of years ago, together with my wife and with Carina, we developed the Mind Matters Clinic concept, which really is a comprehensive way of addressing the needs and services of children and adults with those three disorders. It really is a passion because it really is a big unmet need, and certainly that I felt that, and I felt very gratified in being able to finally offer hope and help to families who haven't yet been able to find that, not only to provide the service or to provide the diagnosis, but just to provide a heart to people who have been struggling for such a period of time and have really never found a way to get help from somebody who shares an interest and a passion in finding those resources. Individuals with these disorders aren't always easy to either identify or to treat. They do require more time than most physicians can provide, or that most school districts can provide by themselves, and so oftentimes they really do need more time, essentially, more specialized services. And Carina, I know this has been an area of interest for you, and that's obviously how we met, and I'd like to, how is it that you see that for yourself?
Well, I had worked in the schools for about 15 years, and as a school counselor and then as a school psychologist, and what I found is that I wasn't able to dedicate the time that I wanted to the families who had these children who had ADHD and autism and learning disabilities and related challenges, really. And so I was looking for an opportunity to be able to provide more comprehensive long-term services. I just felt like working in the schools was so limited in terms of time and resources and that kind of thing. So I too am very passionate about being able to help families in terms of understanding what's going on with their child, or adults in terms of understanding what has happened to them in their life and how to overcome these challenges that they have. So that's what got me into it.
And again, I'm sharing that passion and understanding where people are struggling and those challenges that they have. I know that oftentimes I find that having people come in and being able to identify with their struggle really helps them, because all of a sudden they really feel like they can glom onto somebody that says, I understand, we can help.
You're not alone.
Right.
Yep.
So to back up, describe ADHD. ADHD, by definition, is attention deficit hyperactivity disorder. And it's actually a combination of possibilities, and I know there's 3 types of ADHD. Can you describe the 3 different inclusions?
Sure. So the American Psychiatric Association is who tells us the criteria in terms of making a final diagnosis of ADHD. And so there's 3 subtypes. The first subtype is ADHD combined type, which would be both the hyperactive impulsive piece and the inattentive piece. The second subtype would be ADHD predominantly inattentive type, where we don't see the hyperactivity and impulsivity as much. Oftentimes you'll hear that referred to as ADD. And then the third type is ADHD predominantly hyperactive impulsive type, which is where you see a lot of the physical activity and moving around and having a hard time controlling themselves. So what the criteria says is that these behaviors need to have been present for 6 months. And so along with that criteria, we also use a lot of tools in our clinic to assess for ADHD.
Because what we find oftentimes is children with ADHD, very rarely in my experience as a child with attention deficit disorder, have just that. That oftentimes, unfortunately, they have other things that are going on. Either as a result of having attention deficit disorder, they develop emotional problems, behavioral problems such as anxiety and depression. They may have problems with learning problems. They may have obsessive compulsive disorder. Certain learning disabilities is a very common disorder. I know in your experience you see that frequently. And it's not just one type of learning disorder, but it can be several types. At least a third of children with ADHD have a learning problem. And all these things will change the face of ADHD. And sometimes what I like to describe when I talk to parents is that if you have a child with ADHD and then you apply that here and you see, okay, that's what a child looks with ADHD. Well, if you take a child with ADHD and has a learning problem, then all of a sudden that changes the way the picture looks. And you can add to that, you can add depression and anxiety or obsessive compulsive disorder, Tourette's syndrome. There's a variety of other things which always changes the face of ADHD. And I know sometimes I will have parents say, well, my friend has a child who has ADHD and he doesn't look anything like my kid. Well, oftentimes that's because they're very different as far as the other things that are going on with them. So specifically, it's a very common disorder. We see ADHD in approximately 9% of individuals in the United States, making it the most common behavioral disturbance in children when they've done large-scale studies. So if you picture that, that's approximately 1 out of 10 kids in a classroom that are going to have ADHD. So it's very common. It's also genetic. I mean, there's approximately 50 to 75% of the time you'll find an individual with ADHD has a parent with ADHD. So sometimes, surprising, we'll find out, we'll have a child come in for ADHD, and I'll be talking to the mom, and the mom will say, that sounds just like his father. And we'll go, I wonder where the gene came from. I think we found it. So oftentimes you end up treating not just the individual, but you treat the father or the mother. Not picking on fathers, okay, but it can be anybody in the family. It also makes a challenge if a parent has ADHD to know how to parent effectively. The flip side of that is also sometimes as you're identifying it, one parent will see their own life as having been normal, that their ADHD didn't impact them, even if they didn't graduate from high school, may have had problems. And so sometimes it's hard for them to identify it in their child. So how it looks to one person might make it look different to another. If you have a family that's very rigid and military, then any hyperactivity or going outside of the rules might be more distressing than in a family that's in constant chaos. They may not notice that kind of a thing. So it always looks a little bit different, both because the individual is different and then also in the context of the family they see. What kind of things do you usually see in the school setting that would alert a teacher to talk to a parent or let them know?
Really common would be when a teacher gives a direction and the child doesn't know what to do. So he's, just sitting there doodling, or so oftentimes we'll see things like not being able to follow directions. Their time on task is not very long. They're only able to do work for maybe half the time that their peers are able to. work completion. They're not turning in their homework, or the classwork is not complete. Taking a lot of breaks, maybe unnecessary breaks to the bathroom, or sharpening their pencil. And as they're going to sharpen their pencil, they're stopping and talking to some friends and playing with this thing over here. And so what the teachers report is just a lot of redirection of the child. Okay, I need you over here. What did I need you to do? And a lot of prompting to the task. And so then on the playground, you're hearing a lot about impulsive behaviors, throwing the ball inappropriately at a friend, or saying something that really hurts a friend's feelings. And so those are typically the things that we see at the school. Mm-hmm.
Breaking down each item, I'm going to focus first on focus. That's a good one. We'll focus first on inattention. Inattention, in my mind, is not really a lack of being able to pay attention to something. It's the inability to really to focus on what's important. Mm-hmm. So in any moment in time, you should be able to say, there's a lot of things going on in my environment. I feel things, I hear things, I taste things, I see things. But of all these things, which one's important? Which one I should be paying attention to? So you focus. Basically, you exclude those other things that you're not paying attention to. You dampen them down, and then you zero in on what it is you're supposed to be paying attention to, which may be more than one thing. But there's essentially infinite numbers of things that you can be paying attention to at any one time. So the question is not really, can a child pay attention? Is he paying attention to what he should be paying attention to? And there's going to be some environments where that's more important than others. If a child is outside and he's running around in a park, or he's down at Stanislaus River and fishing and running around and jumping on rocks and things like that, then what he's paying attention to at that moment in time is less important than it is perhaps in a classroom setting, or at church, or in the home when they're supposed to be doing certain things or doing certain chores. Mm-hmm. Of course, it's always good to pay attention if you're jumping from rock to rock, how far the rock is, so you don't, dump into the river, things like that. But it's a limited amount of attention they have to be paying attention to. I picture it as a soundboard where you have the ability to dial up certain things you want to pay attention to and dial down other things, and that may change over time. You may say, in this situation right now, I'm paying attention to the TV monitor. Now, if somebody were to walk through and pass right between me and the TV monitor, then I would probably pay attention to that person and probably scold them for doing so. But that would be something where I could shift my attention even for the moment and then go back to what's important. That would be dialing down certain things. Mm-hmm. What I find with children with ADHD is they can't make those adjustments. They can't modulate their attention to what's important. So instead of paying attention to what the teacher's saying, they pay equal attention to what the teacher's saying. All the sound things are turned up, so they hear what she's saying, but they also feel there's something that's under their seat, and they notice there's a child next to them who's doing something with their pencil, and they hear a sound outside, and they're all competing at the same volume, so they can't really separate those things. Mm-hmm. So though they may hear bits and pieces of what the teacher's saying, it's competing so much with these other things that they can't make heads or tails of it. Mm-hmm. So sometimes I get accused of looking at you and never really registering what it is. Mm-hmm. And oftentimes you'll have parents say, I have to tell them 2 or 3 times. Mm-hmm. Well, maybe the first and second time, they were looking right past you at something that was in the background they were paying attention to. So they really can't pay attention when they're supposed to. Mm-hmm. Impulsivity, I picture that as being something of saying, should I do what I think I want to do right now? And so when a child is thinking in that sort of a way, they have to send it up to the coach, which is the front part of their brain. Mm-hmm. And they have to ask the coach, is it okay, mother, may I do what I'm thinking I'm going to do? Mm-hmm. And if they don't get the response back, then they'll end up doing it. And then we know that makes them look like they're misbehaving, or that they don't care, or that they're being mean, or that they are being disobedient or disrespectful to someone, because they go ahead and do the action, and then oftentimes right after the action happens, they know they blow it. Mm-hmm. They've blown it. So then they recoil, they back up, but it's too late. They've already done it, and now they're in trouble. Mm-hmm. And then they try to not do it again, and they screw it up again. So when I see a child who's being impulsive like that, they're usually getting hammered a lot. They're usually getting scolded a lot. And I know that also translates to the school setting. What kind of things do you see in school that happens?
So impulsivity would be the child that comes to mind for me is blurting out. It's things that are off topic or wanting to answer. Right away. They know the answer to everything, or they're raising their hand, constantly wanting to be called on. And then
So they're good participators.
yeah, yeah. And then, as I said, just on the playground, engaging in really, kind of impulsive behavior, saying things that they shouldn't be saying, or maybe in the cafeteria, throwing something across the room and not thinking about what the consequences are going to be in terms of with administration or with their peers,
Who doesn't think about throwing some food across the cafeteria when especially when you're a boy? I mean, everybody kind of fantasizes about that, but don't do it. Coach says, don't
Right.
do it.
Yep.
Yeah. So does the coach get there in time? Yeah.
Right.
So that's the hard part for those kids. And then sometimes they start to develop habits where they know that they're going to get in trouble, so they start to develop really sophisticated ways or not sophisticated ways of just learning how to respond. My favorite example is the why question that a parent will oftentimes ask. A child will do something, he spills something for the 100th time, and the parent will be right there in their face to say, why did you do it? And instead of a why answer, they just kind of look at them and what are they supposed to say? There is no answer to a why question because they just did it impulsively. They didn't think, gee, I really want to make mom mad at me. I think I'll knock over this cup of tea for the 10th time. So they come up with saying, I don't know. Or they say, I did it on purpose. They'll say anything to make the parent go away, which just makes the parent more frustrated because they didn't really get the answer they wanted. The answer they wanted was, what? There is no good answer. There really is no good answer to the why question. So that's where impulsiveness happens. A hyperactivity would be the third part of it that not all kids have. And we should give a brief description then between a child who's hyperactive and one who's just inattentive. Now, a hyperactive child would be a child who really can't sit still. They're moving around, they get up out of their chair, they can't sit still at the dinner table, they can't complete homework because they have to get up and move around. They make excuses to go do things. They're constantly fiddling with things, which then they drop on the floor, makes a noise, makes a commotion, and creates a problem. Same thing at home. They tend to be a little bit clumsy because they're kind of always moving, and so they break things commonly. They can't assemble things very well because they're going too fast. They also have verbal hyperactivity, which is not something you really relate to. People always think of hyperactivity as just a boy moving too much. But verbally hyperactive kids just talk too much. And in classroom, that's a big problem. So they go going on and on. So the most common picture you have of a child with ADHD is a boy, because they're diagnosed more commonly than girls. And boys tend to be more boisterous and rambunctious to begin with, and you add a little bit of hyperactivity, then you've got a boy on steroids. Because now all of a sudden he's bouncing around and making himself really obvious to the teacher that there is a problem. So usually a boy with combined ADHD will be recognized much sooner because they're obviously more disruptive and more annoying in a sense to a teacher, raising concerns and to parents. But then there's an inattentive ADD child. Can you describe me what you would paint a picture to a parent for a child who's just inattentive?
So that would be the child that oftentimes I hear the word daydreaming. It seems like they're always off in la la land, teachers will say, and just not really tuned into what's going on in the classroom, just having a hard time being able to sustain focus for long periods of time. So they might hear the first 2 minutes of what was said, but then be totally somewhere else later on. Oftentimes they are also the ones that tend to not complete their work because they get maybe halfway through the assignment and then they're, started drawing, or they would rather do something else than the assignment that they've been given. So work completion can be a problem. I think that's probably what I would describe in terms of inattention in the classroom.
And also I could picture the ones that the same thing with organization and getting their homework in, but they're oftentimes very pleasant. So they're not annoying. So teachers don't actually mind having them around. They're just kind of concerned of if they would just, do more, if they work a little bit harder, if they wouldn't spend so much time daydreaming. Oftentimes I'll see that in report cards from teachers. Teachers will say, gee, we really loved having Susan in the class, but she sure daydreams a lot. It would be nice if she focused more, if she tried a little harder. So oftentimes they'll go on later until they become diagnosed.
What might be helpful is to talk a little bit about how this would present in an adult.
Oh, yeah.
Yeah.
Children with ADHD, since we know about 9% of children have ADHD, not all children who have ADHD will grow out of the disorder. And that was a common belief actually when I was a resident 20 years ago, that virtually all children, once they had ADHD, when they hit adolescence, they would grow out of it and the disorder goes away, and there was no such thing as an adult with ADHD. Adults with ADHD are common. Approximately a third of children with ADHD, a third to a half, depending on the study, will still have a diagnosis of ADHD as an adult, but they look a little bit different. Oftentimes adults will find themselves, first of all, in a setting where it's less obvious that they're ADD. An adult who has to sit still, has to do sequential processing, who has to do a row of numbers, they probably won't be ADHD because that wouldn't be a place that they would gravitate to. So instead they look for things where they can perhaps stand up and move around. I've had freelance photographers, car salesmen, lots of people that you wouldn't expect to have ADHD who have adapted to it to some extent by finding an environment where their difficulty with organization or with being hyperactive in a sense is less obvious. It can still be a problem though if you're married. Because if you do something impulsive and you say something really stupid, like how many times you think you might want to say something to your spouse and you go, Coach, should I say that? And then you say it, oh man. So then you're paying for it for a week. And if you have ADHD, then adults with ADHD oftentimes will have a lot of struggle with marriage and with relationships, with their boss, not turning in their pay sheets or their time cards or completing the documentation they need. So a lot of times adults need help with their ADHD. What kind of things do you see?
With adults?
Yes.
Let's see. So mostly what I would see is that they're having a hard time organizing their life. So bills aren't getting paid, projects that they've been wanting to do for a long time aren't getting done.
Or jumping from project to project.
Right, like can't prioritize what would be most important in terms of a project at home. Oftentimes I'll hear I start a project and then I'm not able to finish it, and that which causes a lot of marital stress also. Let's see, so that's typically what I see is just that lack of kind of time management, organizational. It's like they almost need a secretary to tell them this is when your doctor's appointment is next week and this is when Joey's soccer practice is. It's just not being able to put all those things in order.
Which is one of those ways of adapting. If you have a great secretary who helps keep your life organized, then if you're less organized, it's not as obvious. So you'll oftentimes find them vocationally in places where they do have that structure given to them. Sometimes in the military. Sometimes people with ADHD do well in the military because, again, the structure is applied for them. They don't have to invent it that way. The other thing I'd like to focus on is how do we know it's ADHD and it's not just a rambunctious kid. I mean, boys will be boys. I mean, my boys certainly know how to bounce around and jump out of trees and do things that look hyperactive. How come it's not just a rambunctious boy?
Well, that is a key part of our assessment. So at Mind Matters, we do a comprehensive assessment that is very individualized. So we use a lot of different measures. The first would be rating scales, which we use a couple different types of rating scales that look at what's happening in terms of ADHD type behaviors and then what's happening in terms of other social emotional behaviors so that we can kind of weed out what it could and couldn't be. So rating scales will be gathered from the teacher and from the parent, also a self-report if the child is old enough to speak of their own behaviors. With adults, we will often use just self-reports. And so what happens is that it's a standardized measure, so it allows us to compare our client's behavior to other peers who are the same age, whether it be an adult or a child, and then it tells us just the severity in terms of the intensity of the behavior and the frequency of the behavior. And we can then target if it is truly ADHD, or maybe it's something more like oppositional defiant disorder or anxiety and depression or something like that. We also do a lot of observation just in the clinic alone. I mean, our waiting room is the perfect place to observe a child. Right. So we're
bouncing off the couch and off the wall.
Yes, right? Exactly. So we do a lot of observation at the clinic. If a child's in my office and can't sit still, is constantly touching everything on my desk and wandering around looking at the horses outside and pulling the blinds up and fidgeting and squirming, after I've prompted them several times and redirected them several times, it's obvious that it's very difficult for them. Of course, oftentimes in the first session, they want to be seen in a positive light, and so they might be on their best behavior, which in that case, it's really important for us to go out into the natural environment and observe them in the classroom or on the playground. And again, that allows us to compare them to their peers in terms of the frequency of a behavior or how intense or severe a behavior is.
And also emphasizing, I know when we're talking about that, it's not just the parent's perception. Mm-hmm. So it shouldn't be a child who has these behaviors just at home, right, or just in the classroom, or just somewhere else. If it's truly a neurologic abnormality of the brain, then it should be something that would be evidenced everywhere. And so that's the way of checking one against another. And I know that you've looked at that before, where you have sometimes a scale that says he's very hyperactive here, but not so much here. Well, what's the difference? Right. Sometimes there's some other stressor that's going on that changes their behavior.
Exactly.
The other thing I want to emphasize is that in doing a comprehensive assessment, many physicians really struggle with the idea that you have 15 minutes to try to complete an assessment. And even if you hand out one of these documents, do you have a time to follow up, to make a phone call to a teacher? Do you have time to look to see if the child has one of these other things which will mask or change the way a child looks at ADHD? If they have a learning problem, or they have anxiety or depression or something, it's really important to ferret those things out, because if all you recognize is this, and the problem is actually much bigger over here, they're being abused at home and have a lot of anxiety as a result. They have a significant learning disability that makes it so they can't hear the instructions well. So that makes it very important to be able to try to ferret those things out so that you really zero in on what's going to be an effective treatment. And I know that's what we are able to offer. I know that it's been great having that ability to have you and having Susan Dex Kearns be able to look at all those pieces. And so I think that's really important we do that. I guess the last piece is that saying, when it comes time to make a diagnosis, is to be able to put them in an order of priority and saying, okay, what things can we address? And then being able to dovetail those things into looking for really satisfactory treatment options. Because if you don't have the right diagnosis, then you're not going to get the right treatment result. And also being able to have the parents come on board and say, okay, we really believe and trust that you've done a thorough evaluation of our child, or as an adult, talking with the spouse and making sure they've really done it the most effective way. From there, then I think we need to be talking about treatment. And so in our next episode, what we'll be focusing on is the treatment of ADHD. And again, focusing, there's that word again, focusing on tailoring the treatment to the child with the most effective treatment, because we really understand the child and really look at the child in a comprehensive way. So in our next episode, we'll be having myself and Carina Lindblom, along with Susan Dex Kearns, who will be coming in, and we'll be sharing some different strategies that we have for working with a child with ADHD. So we welcome you back next time.